All right, Emma, we're live.
Hello and welcome to the NTSA April webinar. Today's topic is a call to action, leveraging simulation to improve patient safety in our post-COVID world. My name is Jim Robb and I'm the president of the National Training and Simulation Association, NTSA. For those new to NTSA, we're a nonprofit association dedicated to facilitating dialogue between government, industry, and academia on topics related to providing the best possible training and training systems for our warfighters and first responders. We host a portfolio of 9 events each year, the last of which is called IITSEC. It's the largest simulation conference in the world. We started the webinar series last year, almost a year ago today, to continue outreach during COVID. As you know, many of our events were canceled or had to go virtual. But we found these venues to be effective and popular, so we will continue on for the rest of the year. Today's event is focused on patient safety, which is a topic that I have passion for professionally and for personal reasons. I discovered the size of the problem during discussions 9 years ago with leadership at the Society of Simulation Healthcare annual convention. From that time forward, we have sought to find ways to increase awareness of what is considered by some to be the 3rd largest cause of death in the United States. We also feel strongly that simulation and training are key components of the solution set, as well as incorporation of best-of-breed safety protocols that are used in other professions like mine, which is aviation. One of my true teammates in this endeavor has been and continues to be Bob Armstrong. He's going to moderate today's panel, and I thank him for his participation. He's a past president of SSH and is passionate about leveraging modeling and simulation technologies to improve patient safety and outcomes, something we have in common. He serves as the assistant professor within the School of Health Professions and as executive director of the Centara Center for Simulation and Immersive Learning at Eastern Virginia Medical School in Norfolk, Virginia. So thank the panel for participating, thank all of you for attending, and I'll turn the program over to Bob.
Emma, Rob, thank you very much. Before we get started, I just want to lead in, have a few things to say to lead us in, and then I'll do an introduction to our panel. So yeah, this is about patient safety. According to the World Health Organization, patient safety is considered the absence of preventable harm to a patient during the process of healthcare and the reduction of risk of unnecessary harm associated with healthcare to an acceptable minimum, right? So makes a lot of sense. We understand generally what patient safety is. The idea of an acceptable minimum refers to the collective notions of given current knowledge, resources available in the context in which care was delivered, weighed against the risks of non-treatment or other treatment. The discipline of patient safety is the coordinated effort to prevent harm caused by the process of healthcare itself from occurring to patients. Patient safety has been increasingly recognized as an issue of global importance. So it really warrants this level of discussion and coordinated thought. Previous research and analysis have shown that between 100,000 and potentially up to 500,000 people die annually in the United States due to preventable medical errors. Assuming about 250,000 people die annually due to error, that's essentially the equivalent of crashing a full Boeing 747 daily in the United States alone. That's a whole lot of people. And the reason that it doesn't get the level of probably attention that it should is because they're not all dying in one place and at one time. So it's just the nature of our ability to really process that level of impact. The panel that we have today, and all of you as virtual attendees of this webinar, I'm sure all appreciate the value of healthcare models in simulation. I mean, that's one of the reasons why you're here. I'm sure you appreciate how models and simulations can support the development of skill mastery and effective teamwork, and how they can be used to assess proficiency and measure performance of critical tasks. So we're looking to discuss how we can further leverage these tools to help continue to make an impact post-COVID. The NTSA and the National Modeling and Simulation Coalition, partnering with the Society for Simulation in Healthcare, have worked to help address this target problem. And we've been involved over the last, collectively over the last several years, to try to bring some attention to the value of modeling and simulation to basically help the United States crash fewer 747s, as I mentioned previously. The Modeling and Simulation Coalition has a unique opportunity to coordinate and communicate with members of the Congressional Modeling and Simulation Caucus. This is a caucus group that is energized to take on the most universal of causes, improving patient safety. Caucus members come together with the National Modeling and Simulation Coalition team at least annually at the Modeling and Simulation Leadership Conference, which will be held this fall in 2021. We had a 2020 event in Jacksonville, Florida that was a well-attended event. We expect to do another one this fall in conjunction with another event, hopefully not virtually. So where does that leave us today? We're here at this webinar, which seeks to draw attention to the types of opportunities and successes that will help inform the national patient safety policies and legislation, and to help keep the conversation moving towards this fall leadership meeting. So let me introduce the panel very quickly. We've got, and we are all very, very fortunate to have this group of folks together today because they all have a strong background in patient safety. I'm lucky to know all of them, and I'm really lucky that they said yes when I asked them to come join us. So we'll start with Connie Lopez. Connie is the clinical practice consultant and simulation leader for Kaiser Permanente's Northern California Risk Management and Patient Safety team. Thanks, Connie, for being with us. Kaiser is one of the largest nonprofit health providers and plans in the United States. Something like 39, 40 hospitals in the system nationwide. There are 700 plus medical offices. You got a little over 300,000 employees and 12 million members as part of the plan there. So Connie is a clinical nurse specialist by background, and we're really fortunate to have her with us today. She's been heavily involved in patient safety, both at Kaiser and with the Society for Simulation in Healthcare. So thanks for being with us, Connie. Next up, we have Dr. Haru Akuda. Haru is the incoming president of the Society of Simulation in Healthcare, so he will be the president for essentially calendar year 2022. I've known Haru for a number of years. He is the executive director of the University of South Florida Health Systems Center for Advanced Medical Learning and Simulation, which happens to be the largest standalone simulation center probably in the world, but definitely in the United States. It's an amazing center, and I would urge you to see it. He's also the assistant vice president for the University of South Florida Health Office of Interprofessional Education and Practice. He's a professor within the Department of Internal Medicine within the University of South Florida Health Morsani College of Medicine, and he is an emergency medical medicine physician. So thanks, Haru, for being with us today. And last but not least is Allison Perry, who is the Director of Faculty and Fellows at the Institute for Healthcare Improvement. The IHA is a really interesting organization. It's been around since the 80s, since the 90s, in its current naming iteration. It's grown from a grant focus to a self-sustaining organization that is focused worldwide on improving the quality of health and health care. So we're really, really fortunate to have these three panelists with us today. And I'm going to jump right into our first set of questions that we're going to work on here. So, oh, and I'm Bob Armstrong, your moderator. And you've already heard a little bit about me. So, panelists, I'd like to first have us discuss about high-level organizational influence and high-level organization influence. So our U.S. healthcare system is really mostly independent. So it's not a government healthcare system per se from a majority standpoint. It's managed at the individual system level. Sometimes those systems are really large, like Kaiser Permanente. Sometimes they're really small, like a community hospital that that many of us have probably had some experience with. However, all of these healthcare systems are bound by federal, state, local laws and policies. There are standards of best practice that are enforced, and sometimes just recommendations. There are certainly ethics, and there's just common sense on how you provide care to somebody. A challenge to our system in the United States is to ensure that patient safety efforts are applied consistently across the country and throughout these healthcare systems. So I'd like to start, and Allison, maybe we'll start with you on this. How do strategically focused organizations like IHI or the AHRQ, for instance, how do these types of organizations influence patient safety? How does that come about?
Thanks, Bob, and hi, everyone. It's nice to be here. I think this is a really important question. I think it's a question that that we've been grappling with for a really long time, the role of regulation and policy. I definitely think that regulation has helped to make patient safety a priority as a requirement. It has established mechanisms and national systems for reporting and responding to events. So in that sense, the consistency of policy and regulation is certainly key. But patient safety as a whole is much bigger than the event reporting and the regulation. And it's really until leaders and the workforce understand patient safety and get on board with patient safety, including the regulation and the policy, but the underlining issues around patient safety, only then can regulation and policy be helpful, and it can only take us so far. So what organizations like NPSF, the National Patient Safety Foundation, who now merged with the Institute for Healthcare Improvement, what organizations like NPSF and IHI have done is to create networks of people by which patient safety and the innovations behind the patient safety issues are able to be spread.
So those networks, are they nationally focused, or are they state focused, or how does that work?
Well, I think some are more formal than others. So I think I'm thinking of networks in the broad diffusion of innovations theory sense. So networks of thought leaders and individuals who are working towards a common cause. But we certainly have formalized networks, even within an organization are there networks and people working towards a common cause. So, and then in turn, creating learning systems from those networks where learning and information is shared and passed along to the next.
Gotcha, thanks. Connie or Haru, do you have anything to add to that?
I do. Haru, would you like to go first, or?
After you.
Okay, great. So thanks, Bob, and hi, everyone. So I have a great example of how evidence and regulatory bodies can drive best practice. Recently, the Joint Commission implemented requirements for improving safety in our perinatal setting. The requirements include new standards, 13 performance elements designed to improve quality and safety of care to our women during all stages of pregnancy and postpartum. Because of worsening maternal morbidity and mortality, and the Joint Commission reviewed the literature, and what the literature revealed was that prevention, early recognition, and timely treatment of maternal hemorrhage and severe hypertension had the highest impact on decreasing maternal complications. So as part of the new requirements, perinatal teams are now required to provide a role-specific education to all staff, and that doesn't just include the perinatal departments, but also the emergency department. So all staff providers who treat pregnant patients and postpartum patients about hemorrhage and severe hypertension. And this includes conducting drills or doing simulations at least annually to determine system issues. So not looking just at the individual, but the systems, and then it must include team debriefing after the simulation. So this is really one of the first times that one of our regulatory bodies has supported and helped drive doing simulation.
Thanks for that example. That's really powerful, and it takes that level of kind of large scale coordination and focus to help bring some of these changes to bear, doesn't it? Yeah, I think Haru, you had a comment as well.
Yeah, I just as you know, the four of us have worked together for quite some time, and I think we've been in the pro simulation. We've drunk the Kool-Aid. We know it works. We believe it works, and we know that there's evidence that it works. I think all of our challenges have been that trying to advocate around it and finding ways to incentivize hardwire simulation into existing standards and benchmarks that have been created by organizations like IHI or the Joint Commission. It is really exciting that the Joint Commission is now requiring these drills. And when I saw that back last summer, I got very excited. And we've already started helping organizations meet those needs. We look, to groups like the IHI to set those standards. I think, you talked about these communities, which I think are wonderful. I think IHI has done some great work with the bundles around Central Line, way back when, and giving toolboxes and on how to implement those. And I'm kind of curious where if there's opportunities for organizations like IHI also to require or actually showcase simulation as another tool that could be used in a hospital or healthcare systems bag of I won't say tricks, but bag of efforts in order to improve outcomes, because there are definitely proven best practices, research, evidence-based that does work. So I was a little curious on your perspective, Allison.
Yeah, so I think absolutely there is a role for organizations like IHI in terms of standards and requirements. We don't have we don't issue standards or regulation to a certain extent, but rather tactics and strategies. And that's actually something that we've been working on for over 10 years now, finding ways that simulation can be implemented in existing bodies of work. So for example, root cause analysis and action, we have a new RCA squared. It's not new now, actually, it's about 7 years old maybe, but RCA squared. So that action piece, that's where simulation fits in. So trying it again, and what are you going to do next time? So finding ways that simulation can be used to address existing patient safety issues that we're already working towards solving.
No, thank you for that. So Allison, your organization publishes a report, or recently published a report, I guess, called the National Action Plan to Advance Patient Safety. Which I think, and then so that was a document that was provided and is publicly available. And then the AHRQ recently published their annual report to Congress. Both of these reports highlight specific critical patient safety issues, needs, and solutions. Can you speak to those reports and how they get consumed and how they kind of fit into this solution set?
Yeah, so I think I'll speak from the IHI side, and then I'd love to hear the practical side, so for Connie and Haru, who have to actually do something with it, what is that like? But from our perspective, and just quick brief summary of the National Action Plan to advance patient safety, we were talking about networks earlier, networks of people, and it was actually this work was a collaboration among 27 national organizations, and I think it's important to note that it includes folks from the government sector and on the ground implementing this work, and patients and families were part of this as well too, and that's really important to note. So again, then also going back to the tactics and strategies, they're included in this document along with an implementation guide and measurement strategies. So it's really in some ways, a step-by-step guide to do some of the work that AHRQ is essentially asking everyone to be reporting on and be improving. So it's somewhat like a toolkit. What's missing from it, though, and I think what we're here to talk about is simulation. So it's not part of the tactics and strategies at a very high level, and I think that's something that needs to change. But I'd love to hear from Connie and Haru. Like I said earlier, what is it like to be given a document like the National Action Plan or AHRQ's reports and now do something with this?
Haru, go ahead.
So I can speak on, so CAMELS is set up in an interesting way. We're linked within the university, but the university itself doesn't have a hospital per se. We're affiliated with a level 1 trauma center very closely, and so we work collaboratively on projects. I know our affiliate, the level 1 trauma center, Tampa General Hospital, has actually consulted, or IHI is consulting for them to help implement some of these areas. And so I think they've done, their CEO is really looking to get to zero harm. And they're taking a lot of these best practices, these toolkits, and applying them to their hospital system. I think where I was struggling was, when they start talking about infection rates and other things, and they have all these great toolkits, and then I'm like, I want to scream simulation, but it wasn't a part of it. And then even afterwards, I said, well, what about simulation? I raised my hand, I try to push it, and they said, yeah, you can use that as well. But, I feel like that should be one of the main, bundles, simulation, even like having these cases that really work and been vetted. I would love that to be able to be offered, not just at our hospital, but at hospitals throughout, because then, when you start putting those in as actually valid resources and efforts, then hospital leadership or C-suite says, oh, maybe we need to build our program. Maybe we need to put some resources into education, simulation, process improvement, human factors things. And it's very powerful. I think the Joint Commission piece will enable at least obstetrical or perinatal organizations to put some resources there, because now they have to meet those requirements. So I look forward to one of these days having simulation as a part of the toolkit that hospitals have to implement.
Yeah, for speaking from the perspective of inpatient and Kaiser, it's very helpful to have the toolkits available, these resources. I think what I would like to highlight and make him out in some of my other examples is how important it is to collaborate with your leadership, and specifically patient safety, risk, and quality leaders within the organization to know what's in the toolkits, really understand the initiative, and how to support our teams in making these actions go into action in our clinical setting.
And if I could just add one more comment to that that I was thinking about as you were talking, I think Kaiser has really set a good standard for using simulation to improve patient safety. And there's actually quite a lot that IHI has learned from Kaiser. But I think overall, and as a nation, I think simulation for many organizations, not all, for many organizations, simulation is still a nice to do, nice if you have the funds to do, but what it needs to be is a must do. in order to continue along this path.
Thank you for those comments. I have one question, then I want to shift gears just a little bit on us here. But so the toolkit, for instance, Allison, that you mentioned that is out there, and Haru and Connie, many of the different things that have been provided from these higher agencies, they're typically, or am I correct in that they are typically low to no cost, like activities that you can take on and harness and use, but there's not a lot of cost in acquiring the knowledge or the intellectual property of some of these toolkits. Is that your experience, Connie or Haru?
I think there's no cost to implement there's no cost to acquire the knowledge, but there is a cost to implement, right? So if you're going to stand up teams or bundles or other things, there's definitely a cost. And I think that's where the reluctance often is, because they have competing priorities for funding.
Yeah, and
there are
oh,
sorry, I just wanted to let Bob know there are a few questions that are starting to be published related to this, so just wanted to give you a heads up on that.
Thanks. Yeah, Connie, you have something to add to that?
No, I'm just going to add to what Haru mentioned is while these toolkits are very helpful, it's who's going to take the time to implement them. And so, one of my examples is, driving down surgical site infection rates versus post-cesarean section. Many elements to the bundle, lots of resources, but who's going to be the boots on the ground person to help train our teams and cheer them on, as well as audit and sustain the gains of the program.
Right. It speaks to some interesting challenges around anytime you mandate anything, or that you can't mandate something without the resources to implement it. And that's why when things are when they're cheaper to acquire, then you're going to have to implement it, whatever you do anyway. So there's kind of an understanding that there's that implementation cost on your end. But it's how do you force simulation to be used? I think for a long time we've tried to make simulation. We've tried to sell simulation in healthcare as a boy. Look at the gains you can get from this. But sometimes those gains cannot overcome the fact that you're dealing with an institution without the funds to do it. To not just buy the equipment, but also hire the people to put it into place and to use it for you. So it's a real challenge. I'm going to real quick. I'd like for us, if we could, to talk here about the Veterans Health Administration and Kaiser specifically. Both of Kaiser, like I already mentioned, a really large healthcare system, and the Veterans Health Administration, another very large system in the United States. Haru, we're going to start with you. I failed to mention this when I introduced you, but you have a history as the National Medical Director for the Department of Veterans Health Administration's SimLearn program. And SimLearn was is the simulation learning, education, and research network that is, I believe, run out of Orlando, not just up the road from you. How were you able to deploy simulation effectively across those 150 different medical centers to support patient safety needs in that system? You want to talk about that a little bit?
Sure, I'd be happy to. And I think this is a good lead in off of the last conversation. So back in 2009, I believe, the idea of a national simulation program for the Department of Veterans Affairs was approved. I came on in 2011 as, I think, the third hire for the program. And, I think this is an example of an organization that decided to put resources and significant commitment to improving patient safety and quality for our veterans through the use of simulation. It did take a significant amount of resources, but they understood the value and the power of simulation to improve patient safety. And so, the approach was to build a hub and spoke model, understanding that not everything can be done at a national center. Not everybody's going to fly from 150 hospitals to Orlando to do training. But standardization was extremely important. I think in healthcare, we see a lot of one-offs, or we see a lot of, even in a hospital network, they do different things in different hospitals, and they all report up to one broad organization. And so, we built from a structure and sort of a logistics and operation piece. We built a national center. This is where we would build curricula that would be rolled out to the 150 hospitals, focused on patient safety issues that we were seeing throughout the organization. We link closely with the National Center for Patient Safety, which is the VA's organization that looks at all the RCAs and quality and safety issues. And then we built, working with subject matter experts, curricula to address this. I think you'll ask on a later question a little bit about what types of patient safety programs we've built, but just to list off, the first one we did was airway management outside the operating room. Others included central line training, and others included hospital activations training. The video looks a little strange, but maybe it's just me. And so it was extremely successful, and it still continues to be. We did really look at it as a turnkey solution. So we bought all of the equipment to roll out to the 150 hospitals, including mannequins, simulators, airway things, built the national content, and then we rolled it out, and then we did certifications, and it became a requirement at the hospitals. There's actually a directive attached to this. So there's some questions around the carrot and stick. You definitely need the stick, which is a directive or policy or some regulation, but the carrot is actually you're saving lives. You're actually improving professional development, and people really appreciated the level of quality of the programs that we rolled out. And I have to really give kudos to Connie. She was one of the first folks that when we looked to start it back in 2011. We looked at areas of best practice and best standards, and Kaiser Permanente was doing it for so long already, obstetrical training that they standardized across the organization. So we really learned, just like IHI, from Kaiser to understand how to do this. But I think it's been effective. I think organizations need to really look at it in a very systematic and standardized way.
Oh, thank you, Haru. So Connie, from Kaiser, what sort of top-down efforts did Kaiser put in place that really moved the needle with, hopefully around things simulation-based, but anything that moved the needle on patient safety for your organization?
Yeah, thank you. And Haru, nice introduction to what I'm going to share. So one of the most impactful programs Kaiser has implemented to improve patient safety nationwide, so across the U.S. where we have our Kaiser members, is the perinatal patient safety program. It was initially driven top down, but is now being sustained bottom up by our frontline staff, which is really exciting. It's been at least 12 years. So after the report To Err Is Human was published, a team of our Kaiser risk and quality leaders got together just to ask the question, how can we improve? How can we do better? The team decided to look at our data. How has the care been for our patients? What are our clinical outcomes? And so they bucketed the data into 5 buckets. Perinatal was the smallest in number of injuries or harm, but the highest in cost. And I'm not talking just money. We're talking family units. We're talking healthcare teams. We're talking the organization's reputation when there's just, when there's harm to our mom or baby. So we had to start somewhere, and data helped inform us as to where to start. So after the review of the literature as to what we would put in a patient safety program that would be successful, we had many elements, but simulation was absolutely one of the key elements after looking at the aviation industry and the military. What are other organizations doing, not unlike us, that has driven, the needle to the positive end. So, and as one of our participants of our patient safety program said so nicely, is that all the elements of the program were pulled together and wrapped up and tied in a bow with the simulation, because they were able to practice all the skills such as assertion, escalation, communication and teamwork, fetal monitoring, and having conversations around what to do for our babies, moms and babies during labor. So the program started in 2002 and was rolled out across the country. I can share with great pride that once the program was rolled out across the nation, we had a decrease in our birth injuries by 50%. So the program worked. And I want to say that simulation played the biggest part in it, because it just brought teams together so that we could have discussions around, what are we doing well and what could we do better. We did a deeper dive into our data and really focused on some of those top areas we needed improvement, which included hemorrhage and shoulder dystocia, which is a difficult delivery, mom and baby. These programs are still going strong. And as I mentioned, they're being led by local leaders. But what I would like to highlight, tying back to our last question, that our most successful programs are those that are under risk and quality. Really collaborating and having those relationships with our risk and quality leaders so you know what the data is, and you have strong support because they have an umbrella over all of the care for our patients. And most recently, this is that we are developing a program, standardized simulation-based program. So we've learned from perinatal, we're spreading it to other departments, but also to other programs such as fetal monitoring, hemorrhage, hypertension, and preventing surgical site infection.
Oh, Connie, thank you very much for that. It's interesting as I'm listening to what Haru's explanation and your explanation here. It seems, and this is going to be so common sense, but at the same time, it doesn't always happen. The programs and their implementation, there was a great deal of energy and time, I think, spent making sure that these were valuable, not just to the patients, but also to the staff, that there was and that the value was recognizable, right? I mean, you could argue that anything that should improve patient safety is worth doing. But the reality is you've got busy hospital staff that are busy actually taking care of people that typically don't have chunks of their day carved out for them to train or to practice things on. It's all kind of OJT based. And so for these things to be embraced and really owned, they've got to have a really, really strong value proposition to them that I think everybody can get behind. Would you agree with that? Anybody? Connie, you're nodding your head. Anybody want to?
No, I give Allison and Haru a chance.
Yeah. I was looking at who wasn't muted, so I guess everybody's with me on that one. So, but I think it's really important, and it's important to remember, I think, within this whole thing that while we're talking about a big giant hospital system like Kaiser or the VA or Centera health system across the street from where I'm sitting right now, that the practice of healthcare is executed in small teams. It's not executed in some gigantic organized effort that happens with 1,000 people doing the same thing and focused on one singular specific mission. There's a general mission that they're following. And so it makes it hard to ensure that evenness and that consistency actually applies, which is why the value at the very small level, at the tactical level, thinking about it from a military standpoint, really kind of matters there. So, there's some questions here that are relevant to what we're talking about here, and I want to kick up on a couple of them before we move on. And if we don't move on to some of the next stuff, that's okay. My friend Ben Baker, thanks Ben for being on. Any thoughts on how potential legislation, specifically requiring simulation activity to reduce patient error, would best balance the carrot and the stick? Many smaller hospitals, clinics, and nursing homes, unlike academic or large systems, would be implementing simulation de novo. So, any idea around how do you balance the requirement to use simulation and the fact that not everybody is created equally when it comes to resources?
Yeah, I mean, I would say the simulation doesn't have to be expensive to be effective. And, right now, there's a lot of training. There are a lot of training requirements for physicians, nurses, other healthcare providers that, I wouldn't say that they're useless, but there are some that are just not, they're more checking the box, but not, and we spend hours on training. Instead of trying to pile on additional training, I think you have to look at, building some programs that are meaningful that might be able to address these patient safety things and replacing existing type of maybe online training or screen-based training that, is currently there. As far as, resourcing these smaller places, I think, safety is an investment. And people don't think of it as an investment. They think of, spending money for education or those things that's not going to generate revenue. But ultimately, as you can see from Connie's example, I mean, significant safety improvements, which ultimately is going to reduce malpractice and other things. So I would say an organization would need to invest in it. They have to invest in both equipment, but also personnel and time for the teams to actually go through the training. I think there are all the different investments. I think it'll be important for government to create some incentives as well, right? So if you implement simulation, they'll get, maybe some grants or other things that will really bring an uptick of the use of simulation. And eventually it should be like everything else, right? I mean, everything like, EMRs and other things that initially back in the day were like, well, I don't want to buy a computer or multiple computers. I mean, eventually everyone had to come around and do it because, they actually saw an improvement in revenue. So, those are just my thoughts.
I'll add some of my thoughts as well too. And I think that just like patient safety and really understanding the core of what we mean by patient safety, I think the same is true for simulation. So for organizations to really understand what is simulation, there's often a perception that it requires a lot of the high fidelity and a lot of the bells and whistles, if you will, and a lot of very useful simulation can be done just by having a conversation, running a simulation with a standardized patient. So yes, eventually, I think it will be important, just like computers, for everyone to come around. But it's not just running the drills, which are so important, but also the more simple, Connie and I have done some things together for the patient safety community, and sometimes it's just putting together a plastic bag with the towel wrapped in it. And so there's a lot of creative ways to go about implementing simulation. And I think that's actually one of the most fun aspects of simulation, is how we can use our creative side to address very clinical and serious issues.
And I'll just add a few comments to both Allison and Haru's thoughts. Grant funding, absolutely helpful in getting, yes, you can do it very simply, but even a standardized patient can cost. And equipment, if you're going to be doing really complex scenarios, such as intubating a patient, we're not going to want to be doing that with our staff. But what I have, what I'll add to this is really thinking about the ROI. And Haru mentioned we're already spending millions and millions on training and education. We're needing to do that, onboarding and refreshing our staff on education skills and as new initiatives come on board. But simulation helps to engage our learners or engage our staff, so that what we teach, what we train is actually changing behavior, and engages our teams to actually think about changing their behavior. And so just thinking about how effective our education is, and thinking about the outcomes. And I'll just mention, as we pull our teams together in simulation environments, we're helping them to work on teamwork and communication, because as emergencies happen, we don't work on our own. And working on teamwork and communication in the literature has shown to improve clinical outcomes. So thinking about that, it is absolutely worth investing the time and money. And so for the smaller sites, even the larger ones, grant funding and just support of this type of education would be helpful.
Those are great thoughts. Go ahead, Karu. Go ahead. Sorry.
So up until the Joint Commission's effort that we mentioned, Connie mentioned earlier around perinatal outcomes, I felt we were going back in sort of negative direction as far as progress goes for simulation, because I early in my career I was very excited that the maintenance of certification for anesthesia was a requirement, simulation every 10 years by the American Society for Anesthesiologists, and I thought, where I envisioned other specialties would follow along, where they required simulations for maintaining the competencies of physicians and teams. But then a few years back, the maintenance certification anesthesia, they actually stepped back and said, well, it's optional. You can fill your requirements in other ways. And that was really frustrating to me, because I thought, they set the standard, they set the bar, and other organizations would follow. So I think, there are some questions around how can legislative or government or other organizations help. I think, in a thoughtful way. We don't want to put too much pressure and challenges to healthcare professionals, especially right now during COVID. I mean, they're just trying to survive. But I think there are meaningful and evidence-based practices in simulation that can actually save lives and actually improve competencies. And so if we can meet in the middle, where there are some requirements around this type of training that's embedded through legislation, I think that would be very important. And we don't have to be prescriptive. Maybe we just say, you have to do some of it, and the local organizations can decide what they're going to do. I think lastly, from a government standpoint, we did have some really great AHRQ and other grants related to more research in this area and how it improves outcomes and competencies and retaining healthcare folks. And many of those grants went away, or research opportunities went away. And I think if funding went towards that, so we can actually figure out which are the things that we do to get the most bang for the buck, I think that would be really helpful as well.
No, Haru, I appreciate you touching on the legislative piece. I was moving towards in that area. It's really interesting, and you made the point about being overly prescriptive, and you got to be careful with that in healthcare. I mean, we prescribed, I don't know now at this point, 10 or 15 years ago, that everybody was going to have to move to the electronic health record, electronic medical record, and the promises of efficiencies and cost savings have yet to be seen by anybody's institution, just because of the lack of interoperability that we have between the different vendors' platforms. And so it's also interesting too that anytime we mandate anything at a high level, that becomes the target that people chase. You've got Goodhart's law, which is as soon as you set a metric to measure against, it ceases to become an effective way to measure your effectiveness, interestingly enough. So from a legislative standpoint, there are certainly people interested in wanting to move this needle forward. I mean, all the members of the Modeling and Simulation and Congressional Caucus understand the potential value that simulation can bring, and how it can be leveraged to help improve these patient safety numbers that we have. But it's got to be the right thing, though, and that's really, really critical. And I mean, there's a lot of a couple of questions here about, well, what's the right way to do it? It's a multivariate calculus problem that requires a lot of input. The most important thing we can do, though, is provide proof that this works as an educational and training component that helps to move the needle that way, which is what certainly Connie and Haru are doing in their practice space. Outside, a question for you: How does IHI directly engage our leaders at the federal level? Is it a purposeful engagement, or is it just through the publish of the national plan that you put out?
Yeah, it's primarily through partnerships and work that we do, like the National Action Plan. I think, though, just to respond a little bit to what you were just talking about, I think that it's imperative for the leaders, including regulatory bodies and governance bodies, to set the standards and demonstrate the importance of first patient safety, and then simulation is a mechanism or a tactic by which you can improve patient safety. So I think it's really important that we first and foremost get that under our belt, that is a critical part of improving care in the United States. And then I think, again, going back to, we need the leadership on board with improving healthcare and using simulation, and that simulation is part of solving the problem. And through that, we need, I believe that I think we need to have the data, and we need to have measurements and metrics in place, because that seems to be what motivates and moves people forward as well too.
Right. So it's kind of the evidence-based, the trust in evidence-based data, right?
I think so, but I think we can't even get there until we have the leadership on board.
Got it. Very good. Haru, Connie, you have anything to add to that?
I just sort of related to this conversation, and maybe just to answer two questions that were asked. I think, one question was just, again, what are some of the largest barriers to gaining more legislative support in advancing modeling simulation to improve patient safety? And then the other question was, what is, beyond medical facilities and providers, what's being implemented as an awareness outreach to ordinary U.S. people, potential patients, which would lead the public demanding simulation training, because they're say, I'd want my healthcare teams to do simulation. And I think, as you mentioned, I'll be president of simulation SSH next year. It's a 5,000 member organization of people that all drank the Kool-Aid, right? We believe in it, and we talk to each other, and we sort of cheerlead each other on. I think what we haven't done as multiple different organizations in healthcare simulation is trying to get the word out to our patients to really demand it. And I think, going to the point of the legislators, I mean, they have so many other priorities that unless, their constituents are sitting there going, I had an error, my hospital's not using simulation, you really need to do this. Unless they hear from their constituents, I just don't think it's going to raise up or bubble up as a priority, especially with COVID and all the other things. I know, every time COVID or Ebola or some disaster comes on, they go straight to the sim centers to say, how can you help us, right? And so maybe we should be leveraging this COVID pandemic to get on the radars of legislators. But I think those are some of the challenges that we're dealing with.
All right, thanks, Haru. Connie?
I'll just add. Yeah, thank you. Gosh, I have so much, and we have so little time. So absolutely, I think that our frontline staff really is understanding the value of SIM, because thinking about COVID and the basic, personal protective equipment, skills, that simulation played a huge role in helping prepare our teams or reminding them of these basic skills, preparing for rare events such as, we had an instance in needing to deliver quintuplets. So, and we've used it for RCA and thinking about, not just talking about what we need to do, but actually testing it to see if our action items are really effective. Our public, and then this is the last thing I'll mention, is I think our public is actually thinking that we're already doing this. They expect it of us. And my short story is pulling equipment off a big truck in DC. I was going to bring the simulators into our board of directors to demonstrate the value of simulation. And there was a family walking down the road, and they saw us pulling these big dolls off the truck because there were two little children that's like, mommy, look at the big dolls. And they stopped and asked us, what are you doing? And we said, well, we're going to bring these into board of directors and practice for, emergencies. We're a healthcare team. And they said, well, of course. And then they walked on. And it really stuck with me because I realized that that's their expectation of us, and it should be the expectation of ourselves.
Oh, Connie, I agree with you there. I think that's a really good anecdotal story there. It's funny to me that we're having some of the problems that we have in patient safety because I've never met anybody in healthcare that was interested in hurting anybody. It's inherent as healers. And I'm not one. I'm just fortunate to be affiliated with a community that we're really interested in helping people out in healthcare, and that's a universal thing. And so it's the natural bureaucracy of work and the challenges of managing a hyper-dynamic environment and the fact that things change often that are there that are kind of holding us back a little bit, I think, in patient safety. But one thing I think I think this will be the last comment here, and then we'll turn it over to Admiral Rob. The fact that we're talking about it, the fact that we're looking at both low-level tactical ways and high-level strategic ways to move the needle on this, I think is really important and a gigantic part of the solution, because there's not one way to solve this. This isn't a vaccinate and move on. This is a systems thinking problem that requires us to look at all the different ways that we can impact, both from carrot stick to education and training to provision of tools to provision of equipment. There's lots of ways to move this needle, and I think it's going to take us a while to get there, but I think we're going to get there. So, Connie, any real quick last words?
Yeah, thank you. Just from an inpatient provider, healthcare provider perspective, risk quality perspective, my biggest, I think one of the takeaways I want to leave everyone is it's really important for successful simulation programs and improving patient safety is to engage leadership, whether it's within your organization and or Congress, getting involved in collaboratives across your state, just to engage ongoing support for this effective method of teaching.
All right, thanks, Haru. Last words?
I'd say some very similar. I think the evidence is there. People keep talking about, in general, like, where's the evidence? It's there. I think we just need to do a better job communicating it. And if leadership is still like, well, it's just a bunch of mannequins. Maybe 20 years ago it was there, but I don't take that anymore, because there's been some great studies done in many different areas that actually show improvement. And so, like a good friend and chair of emergency medicine way back when said, when video laryngoscopes came out, which is the technology that makes intubation easier, in the beginning, they're like, well, you got to always do the old school way. But he was controversial, and he said, well, unless you're using that piece of equipment, you're practicing malpractice, because it's a better way of doing it, and you're harming patients by going the old school way. I'll say the same thing with simulation. There are certain things in simulation, if you're not doing in your organizations, like mock codes and central line training, I think it's harmful, and it's no longer a standard, and you're practicing substandard healthcare.
There you go. Well, we are almost completely out of time, so I want to thank the panelists for joining us on this journey today. I hope that, I'm sorry we couldn't get to all the questions. This is the kind of thing we can talk about for about 40 or 50 years, I think, unfortunately. But Admiral Rob, I'll turn it over to you.
Bob, thanks for putting together such a terrific panel on a very important subject. The insights were extremely valuable. So I think that this is a journey. It's not this is part of our journey, and we're we're glad to have some more teammates here. It is something we need to work together on. Some thoughts, and I think that I've been doing a lot of research over the last 10 years on this, and one of the things that's very difficult to find are the data. And I know Haru said that it was out there, but if I go through the websites, I cannot find data that helps me justify ROI or the degree to which patient safety is an issue. I mean, the fact that we're somewhere between 100 and 500,000, we just have to be better than that. So the fact that we can't define these things down to where, like in COVID, there's 526,000 people. We know exactly pretty much what's happened, but that's not true in the healthcare system. So that's something that we need help at the strategic level getting eyes on. We're also looking at the incentives and the policies that'll make a difference. And so we engage Congress cautiously because sometimes you don't know whether you're going to get some help or you might get something that you didn't like. So it's important that we attack or go after the leadership at the right level with the right messages. And we're here to help on that, especially at the higher level. I hear a lot of things about funding requirements. And I just look at the huge amount of money we're spending on infrastructure. Healthcare ought to be considered infrastructure. And so when there's trillions of dollars being spent, this is a golden opportunity to recalibrate the way that we identify how we spend money on this important issue. So NTSA is certainly willing to work with IHI and other organizations to improve the use of simulation. I went through the national plan and it didn't say a lot about simulation. I've been through the HRQ reporting. There's almost nothing in there about simulation except for one grant. So we're here to help. We can gather the folks that can help write those paragraphs inside of those documents, and we are dedicated to spend time doing that. We'll also continue to look at our own lane, which is principally defense, but we start with the defense healthcare system, but also the VHA. And I've been involved with the simulation center in Orlando for 7 years with that whole effort. And we're here to help all simulation centers across the United States. This is all part of the thing. It's a crime to have someone come back from the battlefield and then die in a hospital, due to some kind of error, and it's just unacceptable. So we look forward to bringing together these stakeholders at our events and continue to work with you, who are the kind of the boots on the ground. If you're interested in becoming a member of our patient safety working group, please contact me, Jim Robb at jrob@ndia.org, or Linda Brent, who's at linda.brent@theastagroup.com. And we are gathering another network, but you never know. So transitioning, our May webinar will occur on the 25th of May at 1100, where we will bring together the leadership of the 3 simulation commands in Orlando that spend billions of dollars on programs. A significant portion of that is actually on medical care. And so we look forward to your attendance and we appreciate your support. So with that, I'll call it a day. Thank the panel and all of you for attending. Please be safe and have a great day.
Thank you very much.